Hey everyone, thank you so much for joining us as one of our Hogue community education classes. My name is Dr. Kerry Price and I'm an obstetrician gynecologist, a part of Orange Coast Women's Medical Group within the Hogue family. We're coming to you from our beautiful Foothill Ranch health facility. I literally see the sunset out to the left and wish you all could be here with us in person. But obviously for the safety of you, our community, we're continuing our virtual education at this time and hoping it will still be helpful. So what we're talking about today is actually kind of a mixture of topics that we sort of umbrellaed as silent topics in women's health, or maybe topics that are more difficult for patients to bring up with their OBGYN. So I just thought it would be good to go through a couple of these topics just so that way they become sort of out in the open. Maybe this helps you to maybe think about bringing this up at your next annual exam or making an appointment with your gynecologist, but just to go through some topics that I actually hear day in and day out, and I think people don't realize how common they are. So just gonna do a little bit of an introduction about myself so we can get started with the presentation, and then we'll go through some of these topics, and then obviously at the end we have an opportunity for questions. So hopefully this presentation is helpful for you and maybe make your next visit even that much easier. So our next slide is a little bit of an intro about me. So just really quickly for fun, I feel like I always start with a fun slide. So I was born and raised in Whittier, which is actually not that far from here. It's actually right on the border of Los Angeles County and Orange County. So I'm a Southern California native. Before I was a doctor, I held many jobs, including a lifeguard, a swim instructor, an elementary science aide. I was a barista at my college on-campus coffee house. I worked in I don't know how many restaurants as a hostess, tutor, youth water polo coach, and obviously I played water polo myself and was an All-American in college. So I feel like it's a nice thing when you think about your doctor. We're not just doctors, we're not just people working in an office, but we're real people. I mean, half the time we've done the same things as you, had similar experiences, and I feel like that's always a way I can connect with my patients. So I always like to let people know about my real self. I also have two daughters, Julia, who's 9.5, and Emily, who's 6, as well as my other two babies there on the screen. You can see Ginger and Donut, who are mini golden doodles, and they're almost 3. That's them in their birthday hats last year. And obviously the girls named them, not me. So hobbies, wine, very much into wine, tasting it, drinking it, talking about it. It's just a super fun activity for my husband and myself and my friends to go wine tasting. I watch a ton of football, preferably college, but I will also watch pro football. And then obviously exercising, super important to me. It gets my energy up and stress reliever. And you know, I'm an OBGYN, so who can't live without sleeping as a hobby? A little bit about my education. As an undergraduate, I was at Scripps College, which is local here in Claremont, California, part of the 5 Cs. And then I went on to do my medical school at the University of Chicago, Pritzker. So I got nice and cold over there for 4 years and then decided I needed to come home. So I came home and did my residency at UCI, just down the highway, and then joined Orange Coast Women's Medical Group straight out of residency, and have been here ever since. So it's been a nice match made in heaven. It'll be my 8th year this year. So moving along into our topics, the first one we're going to start with is urinary leakage. This is a really, really common topic that I hear patients complain about a lot, and also I can tell that they're sort of getting at that without really coming out and saying what their leaking is and how it affects their life. Now, this would be a good one to start with because it's such a common thing. So there's a difference in the types of incontinence, and that's what we say. We say incontinence, even though that means the same thing. So people say bladder leaks or urine leaks, we say incontinence. And you can see here from the cartoon that there's different types of urinary incontinence. For the most part in the gynecology world, we're talking about these types, which would be stress incontinence. That's going to be your coughing, laughing, sneezing, jumping on a trampoline type of leakage that a lot of women experience. There's also urgency incontinence, which means all of a sudden you have to get to the bathroom very quickly, and if you don't make it there within a very short amount of time, a little bit of urine will leak out. And that actually is from overactivity of one of the muscles in the bladder. Then we have mixed incontinence, where some women have a little bit of both. They tell me that some activities will trigger them. Sometimes out of nowhere they have to go to the bathroom really quickly. And so mixed incontinence is another type that we'll see. And then there's overflow incontinence, which is you don't actually empty out all of your urine when you go to the bathroom. And this is the classic, I feel like I'm done going to the bathroom, and then I stand up and lo and behold, something else will come out. And that just means that our bladder didn't completely empty, and so there's a little bit left over, and that's really common too. So again, this is just formalizing, kind of looking at those types of incontinence. Again, stress being coughing, sneezing, laughing, exercising, lifting up your kid, lifting up your dog, lifting that heavy bag of groceries. Urge incontinence, again, just that sudden and kind of unexplainable urge to void. And it could be, signs of minor things, like that muscle overactivity. Maybe it's your urinary tract infection. But then we also can get into some of the neurological and other medical conditions that can be associated with urge incontinence. Then you have the overflow incontinence, like we talked about, just not really emptying out completely, so we get that little dribble that's left behind. And then mixed, like I said, down at the bottom, just experiencing more than one type. But there's also functional incontinence, which didn't really have a picture, and that's just a physical or mental impairment that keeps you from making it to the toilet in time. This one's not as common, but we still do see it, and particularly it's like people who don't like going to the restroom maybe in public places, or they have other things about going to the bathroom that make it hard to get there in the right amount of time. And so what are some causes of incontinence? Well, the big ones, which are up there at the top, is frequently these are arising due to pregnancy. So we see a lot of incontinence during pregnancy. I think most people who've been pregnant can relate to that, whereas the larger you get, there's more pressure, intra-abdominal pressure on your bladder. And so coughing, sneezing, laughing, certain activities will cause people to leak, and also after delivery. So childbirth is another one. And also, even if someone has a C-section as opposed to a vaginal delivery, we still see some incontinence issues after delivery just based on the change in the pelvic floor, and also just the stress of carrying that pregnancy, and then aging. The other sort of normal factor out there is that as we age, our muscles are different, our bladder capacity is different, things irritate our bladder differently, and so we actually see a lot of incontinence develop with age, even in women who've never had a child or in people who didn't have problems before. If you look underneath, there's also certain foods and drinks, medications that can actually act as diuretics and stimulate your bladder, which also increases your volume of urine and your sort of need to go. Classic: alcohol, caffeine, carbonated drinks and sparkling water, foods that are also high in like spices and sugars and acids, especially citrus, which you would think you're doing something good for yourself, but it can make you go to the bathroom more often. There's definitely some medications that will do it, particularly in the classes for heart health and blood pressure, sedatives and muscle relaxants, because your bladder is a muscle. And then actually weirdly large doses of vitamin C, which again, some of these things are things that people are doing to be healthy, right? You think you're being healthy and you're doing something good for yourself, and you're giving yourself sort of an unexpected issue that you weren't planning on having as well. But we also have some medical things on the other side. Easily treatable conditions like urinary tract infections, which are classically associated with urgency and strong urges to urinate, as well as frequency. And then constipation actually can impact that as well, because it presses again on the bladder, and it's sort of causes that bladder to have an increase in frequency because of space limitations and issues. And then, so what do we do about treatment, right? So different types of incontinence require different types of treatment. There's a lot of behavioral changes that we do with patients, and actually this can lead to quite a significant improvement. So think about that list of things I talked about with eating and drinking, right? Maybe having a food diary, and we actually also do this with patients a lot. Are there certain things that tend to trigger you to have more of these issues? Avoiding fluids before bedtime and making sure that they go to the bathroom before bed, what we call sort of bladder training. The other thing that we do is maybe avoiding some of those activities, like jumping, running, other things that might trigger that, if they're okay with maybe ceasing that activity or maybe modifying that. And then again, alcohol, caffeine. So for people who are consuming a lot of these, we try to reduce that to see if that gets us a better result from the bladder. But then that's more behavioral. Obviously, some people do all of those things, and we're still having issues. So another really awesome non-invasive treatment option that we frequently refer our patients to is called pelvic floor physical therapy. And it's exactly what it sounds like. So just like when you throw your back out or injure your knee or do something with your shoulder, and you go to a physical therapist that helps to retrain those muscles to function in their normal way, it's the same thing with the pelvic floor. Your pelvic floor isn't just one muscle. It's actually a bowl of these interconnected muscles that have different functions and relate to different functions in terms of your bladder as well as the intestine and pelvic support. And so we have dedicated pelvic floor physical therapists like we have here at Hoag Pelvic Health and other locations throughout Orange County that evaluate patients on an individual basis and then go through exercises to specifically strengthen the urinary tract, the urinary sphincter, and also those pelvic floor muscles as a supporting cast. So pelvic floor PT, while it sounds kind of weird, is actually super awesome and really helpful as a non-invasive treatment. And a lot of patients will actually have insurance coverage for this as well, they just don't know that. So that's one of the easiest and first things that we do if someone is looking for more treatment besides behavioral modification. And then, of course, in some situations, surgery is an option for patients that maybe have tried physical therapy and it's not going well, or we've tried a combination of things, or certain medical things that actually require surgery as a treatment. And typically, this is a well thought out, well worked up cause of incontinence, usually in the hands of someone called a urogynecologist, which we're lucky to have several here in Orange County. And that's because there's specific testing that we do in the office, maybe some lab work or urodynamic testing, and that way we make sure that we know exactly what type of problem we're dealing with and the surgical options that might be indicated to give patients a better quality of life. And this is usually why it's sort of our last step, because surgery has risks and benefits. And so we want to make sure that we do everything we can as possible to avoid surgery if it's not needed. So that was a little bit about urinary leakage. Hopefully you found that helpful. And obviously, again, multiple treatment options, multiple causes. So if that's something that's bothering you and you haven't talked to someone about it, definitely we recommend making an appointment with your gynecologist to go through that. Because like I said, there's lots of treatment options based on your history and your medical situation and everything else that's going to lead us in different directions. So the next topic I wanted to sort of throw out there is one I get pretty much every day, probably several times a day, which are questions about vaginal discharge and odor. And that's just something people don't like to talk about. They're embarrassed by that. They think they're the only ones going through it, or that they've never had anyone else in the same shoes. And there's a lot of different reasons as to why it happens. So it's a frequent thing that we talk about in the office during an annual exam or during a separate visit. So there's a lot of normalcy when it comes to discharge and odor, and that's because the vagina is sort of a self-cleaning oven. It knows what to do. It's constantly rearranging its mixture of bacteria and keeping a pH that's going to keep everything happy so that we avoid vaginal infections. And so because just like your intestine, there's tons of different types of bacteria that are constantly ebbing and flowing, we're going to get differences in terms of the odor and discharge that gets produced in that vein. So normal odors, weirdly enough, can be things like tangy, fermented, or sour, which I get a lot of people complaining about that, and it's totally normal. You can have a metallic sort of odor, like almost like a jar of pennies or wet coins, which again sounds weird, but that's a normal thing. Bittersweet or sort of syrupy or molassesy, or even bleachy, like something got bleached down there. And all of those things actually can be super healthy and normal and don't indicate the presence of an infection. Same thing, on the flip side, you see there, normal discharge can include sort of a clear or viscous or egg white sort of consistency. Something might be white or creamy in that consistency. I like to call snot-like, which doesn't sound pretty, but it's not pretty, and that it literally looks like you blew your nose, but down below, which can be that slight yellow or slight green tinge. And then you can have watery or moderate amounts of discharge, and all of these things, again, relate to what's going on with the chemistry of the vagina, where are you at in your menstrual cycle, have you just recently had intercourse? Have you just recently had a change in your medication or your diet or supplements or things that you're doing? So things are going to respond to anything you put in your body, and also things are going to respond based on how you move through a hormonal cycle. So it's really common, especially for people who are still having their periods, to see different types of odors and discharge hit along different points, whether that's the beginning of the cycle, during ovulation, or right before and after a period. So these are all things that your body does to keep itself running, and it's totally healthy and normal. But things also sometimes need a checkup. And so I tell my patients when you should start to be a little more concerned or come in for a visit is when you have an abnormal odor that's maybe in that like fishy or sort of rotten category. A lot of times that might indicate the presence of a vaginal infection. We can find issues with the cervix. We can also even find sometimes like you maybe forgot a tampon in there and you didn't know that that was in there. And so that's a real clear signal to come in so that we can check and make sure that everything's out. But those types of odor tend to be pretty distinct, and they usually tend to stick around and not get better with time, while these other ones will come and go. The other thing is the discharge that can be abnormal. Again, not sort of that top category, which looks like for most people what they'd expect during the course of the month, but if it's bloody or rust colored, if it's frothy or purulent, or if it's kind of really clumpy and cottage cheese-like, and if any of these are associated with pain, burning, or other sort of vaginal symptoms, that should clue you in that these things might not be normal. And it's really important to come in for a checkup. Now, sometimes patients will get sort of the idea that maybe doing some self-treatment over the counter with some of your over-the-counter products like a monostat or a boric acid or other things. But a lot of times it's important to figure out what the root cause of the problem is so that we can make sure that you're using the appropriate treatment. And so we always encourage patients to come in for a visit if they feel that some of these things are not in the right direction or they're not improving with time. So again, when to see your gynecologist, again, if the vaginal discharge is unusual in its color or consistency for you, if there's bloody vaginal discharge, it's not associated with your period, if there's itching, there's burning, there's vaginal swelling, if you see any sort of genital rash or redness, all of these things are not typically things that we'd associate with normal health, and so we'd want you to come in for a visit. And again, we're looking for vaginal infections like bacterial vaginosis, yeast infections, sexually transmitted infections like trichomonas, gonorrhea, chlamydia, other vaginitis, which can be overgrowth of other sorts of bacteria, and then also vaginal, vulvar, and cervical cancer. So that's why it's important, if something's new or different and you're not sure, you can always come in. Worst case scenario, right? It's normal and you just didn't know that, but also we rule out all the other stuff that could be possible. So it's just important to make sure that you're tracking and making sure that you know what your normal sort of is. And as you can see from that list I showed you, there's a wide range of normal, and it's just different for everybody. So it's something that usually over time we figure out together. So again, in prevention of abnormal or discharge or odor, right? What are things that we can do to help not get some of those abnormal results? Wearing cotton underwear and loose breathable clothing, which helps to prevent a buildup of moisture, changing out of your clothes right after you exercise, or obviously when you're swimming or using a bathing suit, getting out of a wetsuit when you're done using the pool. Only washing the outside of your genital area, which I cannot stress enough. This is one of the most common reasons people actually come in with problems is they're overwashing, they're using products in the vagina that just really irritate things. We really want to just do gentle cleanser on the outside, if at all. Usually just warm water in the bath or shower is good enough. We don't want to overwash. We don't want to wash inside. We don't want to use any cleansers or products with dyes or perfumes. All of these things cause more harm than good, so we just want to stay away from that. Leave her alone. The other things that you'll want to kind of see is maybe avoiding foods that increase your odor. Again, you might notice a pattern. Dietary stuff has a big effect on vaginal chemistry and again bacteria levels. Using condoms during sex to prevent the spread of sexually transmitted infections. And also some women will have reactions to semen or ejaculate fluid, so that can be another trigger for sometimes some cause of change in odor or discharge. Again, avoiding douching or feminine sprays or hygiene products that go on the inside of the vagina. You could consider taking a daily vaginal probiotic, which is an oral supplement, just like you take a probiotic for your gut. There's actually a lot of widely available probiotics for vaginal health, and you're looking for ones that have higher strains or higher amounts of the strain lactobacillus, which is pretty easy to find, and you'll see a lot of them online as well as in the store. And then lastly, there's something I talk to my patients a lot about, which I think is not really well known, but there's an all-natural product that many of us recommend our patients to use for minor odor or irritation, called vaginal boric acid. We've used it for years and years and years. It used to only be available at the compounding pharmacy, but luckily, of course, it's 2022, you can find it at Target and you can find it on Amazon in a shelf life kind of available product that's going to stay a while in your medicine cabinet. So looking for 600 milligram vaginal suppository, and you can use this preventatively after events that normally trigger this odor irritation, after sex, after a period, after exercise, and at the first sign of odor irritation as a treatment course. And depending on which product you use, the Killer is a popular one at Target. Boricap is one that's frequently looked for on Amazon. So by using these products, you just follow the directions on the bottle, and that can be an easy, non-antibiotic, non-antifungal, simple enough to do at home way to sort of keep your vaginal pH in good check, and that's what helps restore normal bacteria. So all of these things we try to talk to patients who are maybe frequently encountering odor irritation or discharge changes, and a lot of times these things really help a lot. So my last topic that I thought would be good to talk about was painful intercourse. And that's just because I think that, again, it's another sort of topic that's embarrassing for a lot of patients to bring up, or they think that they're not sure if that's normal or if it's supposed to be normal. And it's something we talk a lot about in the gynecology office. I thought it'd be good to sort of just put it out there. What do we normally see? What can something be going on? So it's just important to sort of make that more into a normal conversation. So there's a lot of conditions that cause pain with intercourse, but overwhelmingly the largest cause is dryness or vaginal dryness. It's the most common cause that we see at any age, regardless of menopausal status or not, pregnancy or not. So pretty much, from the time people start their periods and become sexually active to the time they're menopausal, dryness is the most important cause for painful intercourse. It's more common during perimenopause and menopause because of the changes of estrogen and the changes that occur in the vaginal tissue. But we also see this very commonly in younger women, very commonly around the time of the period when hormonal levels are changing quite a bit and the pH is changing. Very common in breastfeeding women who are in a low estrogen state, and very common also in women who are on birth control. Some women actually have vaginal dryness as a symptom of their oral contraceptive or other birth control methods that they might be using that sort of suppress ovulation and again keep their estrogen levels on the lower side. So dryness, again, can throw off the vagina's balance of good bacteria, and it can happen due to, again, I just mentioned all, birth control use, breastfeeding, menopause. So these are all things that can cause the vagina to be thinner in terms of the mucosa and just produce less lubrication. So dryness is a big one. But we also see other medical conditions, endometriosis, pelvic floor dysfunction, like we talked about with the musculature, interstitial cystitis, which is actually a bladder condition that feels like you're getting UTIs all the time, but the urine cultures are negative for infection. Pelvic floor injuries, and that's something that sort of comes with a history. Infections, both vaginal, bladder, intestinal, abdominal, so all of those things. Ovarian cysts, if the cyst is large or bulky or maybe hasn't been previously diagnosed. Fibroids, because they cause the uterus to be larger, bulkier, and also more inflamed. But then also, weirdly enough, and this has been more and more common, I think just in the past couple years with the pandemic and how that's related to people's mental health, we also see dyspareunia as a somatization or a physical symptom sometimes when people are experiencing depression, anxiety, maybe communication issues with their partner. So that also can actually come up when someone hasn't previously had that problem, and we sort of tie into maybe treatments that they're doing for their mental health or getting them treated for their mental health in order to make their sex more enjoyable and less painful. So getting back on track, what do we do, right? So sex is commonly painful, but it's not supposed to be painful. And so what can we do? What are some easy solutions that people can try? And obviously, what do we talk about when you come to the office for a visit? So again, dryness being the most common cause, using a lubricant is a really easy and inexpensive way to try to make sex more comfortable. And when we talk about lubricants, there are actually different kinds. So water-soluble lubricants are a good choice if you experience vaginal irritation or sensitivity. And these are most of your over-the-counter lubricants, KY, Astroglide, a lot of the stuff you're going to find at Target or in the grocery store. Make sure that when you're choosing a lubricant, stay away from anything that has flavor or heats up or anything like that, because usually it's not going to make anything better. So you just want to stick to something really simple. But then there's also a whole category of lubricants called silicone-based lubricants. We talk about these a lot in the office because they last longer and tend to be more slippery than a water-soluble lubricant. And they also tend to be a little bit nicer in our menopausal patients, our breastfeeding patients, because of those atrophic changes that happen to the vagina. So those are two really easy classes. Silicone-based lubricants, you're not going to see them as much in the store for whatever reason. But going online, obviously there's tons of them out there. One of the ones I highly recommend my patients is something called Uber Lube. A little bit goes a long way. It's inexpensive, and it has a low rate of reactions and sensitivity. That's just something to keep in mind, that maybe a water-based lubricant, if you try it and you don't like it, or it's sticky, or it has a residue, or it causes irritation, then it may just be that we need to switch types, and that could be an easy fix. But we don't want patients using things like petroleum jelly, baby oil, or mineral oil, especially if you're in a relationship and you're using a condom. And that's because any of these types can actually dissolve some of the latex that is in the condom and can cause the condom to be less effective or break. So it's just important to make sure that you're not using any of those types of products as a lubricant, especially if you're using it with a condom. And of course, with any new lubricant that you're using, we just always advise doing a small test area first to make sure that you don't have a reaction or a sensitivity, because obviously we don't want to cause a problem when you don't already have one. So it's just important to think about that. So lubricants are one thing. We also talk about picking the right time. I mean, we're all super busy. Everyone's got 100 things on their plate, juggling multiple things. You don't want to try to have sex with your partner when either one of you is tired or anxious or stressed out. It's not going to go well. So it's important to relax, to be comfortable, and also to communicate that with your partner where, you're not feeling it right now, because it's not going to be enjoyable for you if you're not. So being open and honest with your partner, I think, is a hard one for some patients of mine, because they feel like they'll let their partner down, or their partner's going to feel like they're not wanted, or what have you. But again, it's really important to be open and honest with that communication, because painful sex is not going to be enjoyable for you, and it's not going to be enjoyable for your partner either if they weren't aware of the fact that you're not really wanting to have sex at that point in time. Also, talking to your partner. Where do you feel the pain and when do you feel it? And what things feel good for you? Because then hopefully there's going to be sort of this nice common ground where you're both enjoying the experience, and it leads to being more intimate and more comfortable with those activities that you're doing. So we really frequently encourage our patients to communicate with their partners and to find activities that are enjoyable for both of them, so that we can decrease the level of discomfort that they're experiencing. So in that same vein, trying sexual activities that don't cause pain. So for example, if vaginal intercourse is painful for one of my patients because of her endometriosis or her pelvic floor dysfunction or what have you, we focus on other methods that she can be intimate with her partner, whether that's oral sex or mutual masturbation, or other things that sort of lend themselves to being sexually connected, but not necessarily engaging in vaginal intercourse. And so while it seems, again, like embarrassing or things that people don't talk about, these are normal activities that people do. And so we're trying to find safe and healthy ways for patients to be sexually connected with their partners in case some of these things are not comfortable. And then there's non-sexual but sensual activities like massage, talking about the relationship, doing other things that maybe help increase blood flow and vaginal lubrication, no matter what sort of activities patients have planned. So again, involving their partners and making it, sort of a priority in terms of focusing their attention. And then, of course, not super common, but sometimes taking pain relievers prior to sex, making sure you empty your bladder, taking a warm bath to relax musculature. So these are things that people try ahead of time to sort of get into a more relaxed state, which again improves blood flow, improves lubrication. So we're trying anything we can from sort of a private, at-home way in order to get patients to have a more comfortable experience. So those are some quick topics. Obviously, again, not ones that people love bringing up in the office, but at the same time, I just wanted to sort of put out how common they are. We hear about them day in and day out, so I think that it's really important for patients not to feel embarrassed about that. Also, if you don't feel comfortable talking to your gynecologist, maybe talking to a friend or a family member to see maybe if they have a shared or similar experience. And maybe that sort of opens the door to talking with your physician about treatment options. And, sort of we just go where with patients want to go. Sometimes it's baby steps. Sometimes people come in and want to do the whole 9 yards. So we just want to be here as a resource for patients to ask questions, to make sure everything physically is healthy. It's a big part of what we do. So now I think we have time for some chat questions. So I'll be answering those. So these are some things that you guys sent in for us. So first, if I make an appointment to discuss painful sex, what will the doctor want to know and what might my visit involve? So that's a good one because if you're coming in for painful sex, we're going to think about when did it start? How often is it happening? Has it always been that way or is this a new thing? Any changes in terms of recent medical history, medications, dietary things or exercise? Any change in partners? Any screening that we might do, so a pelvic exam typically is something we'll frequently do at that visit if a patient is interested to check for things like cervical or vaginal issues or infections. It kind of depends on the history and it sort of guides the workup, but for vast majority of patients it's going to be having that conversation with your physician and then usually a pelvic exam as well. Some patients come in and they just want to talk about it and we go through that whole course of history and treatment options without even doing a pelvic exam. But usually I'll recommend my patients to do a pelvic exam because I want to make sure that their physical health is okay and I want to make sure that there's an easy thing that I can help treat like a vaginal infection or a urinary infection or there's an abnormality with the cervix that it's going to be important for me to know that. So kind of based on the patient's history and the clinical symptoms, we sort of figure out what that visit might entail. Yeah. So when should I see my doctor regarding my bladder leakage? Really, honestly, when it bothers you. I mean, this is something where a little bit of leaking totally bothers the heck out of people, and other people come in and are really having a lot of loss of urine before it really bothers them. So really at any stage, but the earlier you come in, the more we can intervene and hopefully find a treatment option that's going to be less invasive and that's going to affect your quality of life much faster. Typically, if someone waits to come in for a long time, we sometimes have to dig ourselves out of a hole a little bit in terms of getting back to those non-invasive measures, but also we don't want people's quality of lives to be affected that whole time. Like, if you're someone who normally runs and then this starts happening and you're like, well, now I can't run anymore, we don't want you to miss out on being physically active and doing something that you enjoy. So really it's just when it starts to affect your quality of life, I tell patients whether that's a little or a lot, that's the time to see us, honestly. So someone asked if it's normal to feel as if I have to pee during sexual intercourse. Yes, very normal. And that's because everything's in a really tight space. So your vaginal canal is literally right downstairs from your bladder and right upstairs from your rectum. So depending on the size of your partner, the size of the vaginal canal, and also if your bladder's full before sex, that can do it too. So it's really common for patients to have the urge to urinate during sexual intercourse. We often tell patients, try to empty your bladder right before sex to try to have the bladder as decompressed as possible, and that helps a lot. But it is normal to feel that. Now, if you're having pain or frequency or burning or something else, obviously that could be that you're having a urinary tract infection and we need to deal with that. But usually emptying your bladder right before intercourse is one of the easiest ways to try to avoid that urge to go to the bathroom. And then usually it's more comfortable in that same respect. And then someone asked, will I get a UTI if I don't pee after sex? So not necessarily, but there is a good chance of one for certain patients just based on their anatomy. The urethra is right at the very top of the opening to the vagina. And so friction during intercourse can sort of stir up some of that vaginal bacteria. And sometimes that bacteria can come up into the urethra and that's what causes the infection. Some women have like an instant trigger that they know if they don't go to the bathroom after intercourse, for sure they're going to get a UTI. Some women, try as they may, it almost always happens regardless. And in some women, we actually have them on a regimen where they take preventative antibiotics after intercourse. So that's an actual normal thing. But we do definitely encourage patients after intercourse to empty their bladder and to try to avoid bacteria being in the urethra, and also to make sure that there's no evidence of bleeding or anything else that would be unusual. So it's not a for sure thing, but it certainly can be more of a risk if women don't empty their bladder after sex. And then another one, can medication cause or worsen incontinence? Yeah, absolutely. So there's plenty of medications that are associated with urinary incontinence. A lot of them tend to be diuretic in nature, so blood pressure medications. But there's a whole host of medications that can cause urinary incontinence because of changes to the bladder wall, in terms of how well that muscle functions, or because of just the sort of the irritation or the sensitivity the bladder has to that medication. So that's one of the questions we actually ask a lot. If someone comes in with new or worsening incontinence, always I ask them about dietary changes, new supplements, and medications. Because 9 times out of 10, that's going to be something that's involved. Oh yeah, I'm taking a ton of vitamin C. Yeah, my doctor just started me on a blood pressure medicine. Or yeah, like I'm doing this new supplement for protein stuff and it has all this stuff in it. So you never quite know what it is, because remember, both dietary and supplemental or medications can cause or worsen or change urinary incontinence. So that's going to be a big one, and that's one of the first things patients should think about if they have new or worsening incontinence is, have I eaten anything new on a regular basis? Have I started any new medication? Have I started any new vitamins or supplements? Because those are big ones, honestly. So that's something that we frequently go through at the appointment. So looks like that was sort of our stack of chat questions. I'm so glad that you guys had the opportunity to ask questions. I hope it was helpful for you. I also hope this information, again, was helpful and just understanding some of the basics, things that we think about when you come in for a visit. But also I hope it encourages you that if some of these problems are happening and you haven't talked to your doctor about it, to make an appointment. It's why we're here. We're here to do your regular checkups, but we're here for problems as well. And if anything, we actually like when you come in separately for problems instead of sort of bundling them into your yearly exam, because we get more time to spend talking to you about it, instead of having to get through the whole annual and then doing the problem as well. So we highly recommend our patients make those appointments to discuss them, and that's something that we do day in and day out in our practice, as well as I'm sure in many practices here in Orange County. And it looks like we have another question. This is a good one. So does hormone replacement therapy help prevent leakage? So yes and no, sort of. The thing we think about with hormone replacement therapy is that, again, right, two at least of the sort of situations I mentioned incontinence in for breastfeeding, our postpartum, and also menopause, are situations where there's lack of estrogen in the vagina. We know that as the estrogen leaves the vagina, we know that there's less support for the urethral angle, and so it's more likely, especially to see in stress incontinence in patients. So in some patients, we actually do use vaginal estrogen replacement to try to help support that area underneath the urethra, and a lot of patients actually see some improvement with their leaking. But that's not necessarily something I expect to see if a patient's taking oral hormone replacement therapy or the patch or the pellet or bioidenticals. So some patients will have a response with vaginal estrogen, but not always. And we don't always see an improvement with HRT because it sort of depends on what the problem is, right? So if the problem is more medication or dietary or supplement related, then hormones might not help. If it's more pelvic floor musculature dysfunction, then pelvic floor PT is going to help a lot more than estrogen or a combined hormone replacement therapy. So it really just depends on the patient. But yes, we do see some patients have some improvement with stress incontinence in terms of using vaginal hormone therapy, because it helps to re-support that urethral angle to where leaking is a little bit less common or less frequent. So that's one way that estrogen can actually be helpful. Yeah, so that was a good question. But yeah, definitely something that, again, if you have questions about, your gynecologist is happy to answer those for you. So it's definitely something, like I said, we see those patients all the time. And again, it's perfectly acceptable, and you have coverage to come in and see us for things that are just outside of your annual exam. And usually, even if you start with me and we figure out what something is, or we start diving into it and the workup involves more people, maybe a urogynecologist, maybe your primary care doctor, maybe a gastroenterologist, maybe a neurologist or a pain specialist or a pelvic floor physical therapist, we're going to address it from multiple angles. And we're going to figure out what patients need. So that's just something, I tell patients to keep in mind, is that at least it's somewhere to start, so that we can start working on that, and hopefully get it fixed or get it to be more acceptable to where they have a better quality of life. And looks like we have another question. coming down the pipe. Liz is writing it for me. You guys can't see Liz. But it looks like, oh, okay, this is a good one. I'm 76 years old and I have only a primary care physician. Do I need to see a gynecologist? Well, it sort of depends in terms of your health and what's going on with you. So a lot of our patients, once they get to the age of 75, sort of have differing views about whether they want to continue seeing a gynecologist on an annual basis for a breast and pelvic exam. Some patients just continue with their primary physician, especially if their primary care doctor is someone who performs breast and pelvic exams, because then we know that you're fully being screened. We just find that these days a lot of our primary care physicians would rather a breast and pelvic evaluation be done with a gynecologist. So what I tell my patients who are sort of in that graduation zone is, you're welcome to come and see me for a yearly breast and pelvic exam so I can make sure we're screening you for breast and reproductive cancers. You can come and see me only when you have a problem. But it's sort of individualized based on the patient. A lot of our patients continue to see us on a yearly basis because they feel more comfortable knowing that they've been screened for breast and reproductive cancers, because that's really what we're doing at that point. But I also have patients who have very competent and thorough primary care physicians. And then if there's a problem that they find in their office, obviously they refer them to me so that we can do, sort of a more higher level evaluation as a specialist. Yeah. Yeah, and we have another question. I think this is the last question they said. So, can uterine cancer and hysterectomy and radiation cause incontinence? Well, that's a threefer. Yes, in the short answer. So pelvic surgery in general. So pelvic surgery can alter the position of the bladder. Also, radiation has a lot of changes that it can cause in the pelvis in general. Bladder issues, we see issues with the rectum as well, we see issues with pelvic floor dysfunction. So anyone who's had gynecologic surgery, especially for cancer-related reasons, it's very common that we deal with these post-operative issues. Also depending on how old were they when they had their surgery, how invasive was their surgery, because there's different levels of radical hysterectomy that involve removing different portions of the urogenitary tract. So it definitely can be something that's related, and we see sometimes incontinence and bladder and urinary issues arise after general hysterectomy. So any form of pelvic surgery certainly can do that. One of the most important things I recommend my patients to do after they've had a hysterectomy, after they've had any other sort of pelvic surgery, is I highly encourage them to do pelvic floor physical therapy. It's honestly, I've said it about 1,000 times, you're probably all tired of me saying it, but it's one of the most easily accessible, non-invasive treatment options that we have to help with these types of issues, especially for surgery when you think about a lot of just the reorganizing of the pelvic floor. So what better can we do than to strengthen that pelvic floor and to get it back working in the connected way that it should? So yes, short answer, it can be caused by different surgeries and treatments to the pelvis for cancer and other things, but it just depends on the situation, and certainly there's still treatment options available. So it looks like that's all of our questions for this evening. Again, I thank you so much for your attention, for all, few of you that watched. I hope that we got to a lot of people, and I really appreciate you taking the time to be with us through this community education event through Hoag. We're here to help you. You're part of our community. You're our patients. So we just want to make sure that you know that obviously we're here to take care of you, and if you have these problems or questions, that we're happy to see you for visits, in the office, obviously as an annual exam or as a different problem visit, but that we're here to help. So again, I thank you for your time and your attention, and for your great questions, and I hope you found this helpful. So I hope you have a great rest of your evening and that you all stay very happy and healthy.